welcome to... Let me try that again. Hi, and welcome back to Broken and Brilliant. I'm Carrie O'Toole with Carrie O'Toole Ministries, and welcome to my new co-host, Jenny Presty. Yay!
Thank you.
And we are joined by a fun, special guest, nostalgic for me. So this is Megan, and I'm going to say your wrong last name because you just got married. So what's your last name?
Swenson.
Megan Swenson. Mm-hmm. And we met at Colorado Christian University several years ago when we were both studying in their Master of Counseling program. Mm-hmm. And you were just reminding me that we were the troublemakers in the back who used to get in trouble for talking.
Go figure.
I know, here we are on a podcast. Imagine that. See, teachers, talking is good.
Yes, gets you far in life.
That's right. Well, I ended up transferring from CCU, and I finished up at Liberty University. I did it online, but you actually did get your degree from CCU.
I did, yep.
Congratulations.
Thank you.
And I saw just recently on Facebook that you got licensed.
I did, yep. I'm a licensed professional counselor and a licensed addiction counselor.
Awesome.
Yeah.
Okay, one other little story that I have to share was so what was funny about our class was it was equally split between students who had just gotten their undergrad degree. Right. So they're 22, 23, 24 years old. Mm-hmm. And then the rest of us who were like 45 to 50. And guess which was which? I don't know. But what was really cool, we were actually in a small group together, too, and we got to know each other really well.
Yeah, we did.
On a personal level, and I loved it because I remember thinking, you're just a couple years older than my kids, but I really consider you a friend.
Right.
It was definitely an intergenerational kind of class.
Very unique.
But there was nobody in the middle. There was nobody who was 30 or...
Exactly. There's a huge gap.
Just very funny. And I remember saying to all of you young ones, how proud we were of you for, first of all, dealing with your own stuff when you were young, rather than waiting till you're in your 40s and going, oh, my life's a mess. I think I better start working on this. You guys were looking at it in your early 20s. It's like, wow, you have a real chance at doing something here. This is really cool.
Yeah.
So that's really neat. I really enjoyed that.
It is really unique. But I would say the majority of the people in our program were in the older category. There was very few of us that were in the younger age range. So,
Well, I think part of it is because a lot of people who go into counseling, it's because they've had counseling themselves. They realize that life is really hard, and sometimes in your early 20s you haven't maybe experienced that yet.
Right.
So...
Exactly. I think you're right on that one. Yeah.
So, anyway, well, tell us what you're doing now.
So I work for a nonprofit substance abuse counseling program as well as nonprofit mental health. It's kind of a unique setup where it's called integration. And so I work primarily in the primary care setting. So in doctor's offices. And I go into exam rooms and meet with patients. But I work collaboratively and closely with the primary care, the psychiatrist, and the mental health therapist, but I specialize in the addiction piece of it and the trauma piece of it. So,
wow.
Yeah.
So you're actually in a doctor's office.
Correct. Yep.
I don't think have you ever experienced that?
That's what I was going to ask. Under what kind of circumstances are you called in? Are you...
That's a really good question. So my title is behavioral health provider. So I'm considered a provider just like a primary care provider would be. But I have the specialty in the behavioral health rather than the primary care setting, which is medical health.
Okay.
And so oftentimes I'll be called in to do an assessment on substance abuse. If they're coming in and they have a history of substance abuse like marijuana use, alcohol use, any other drug use, just to see where they're at risk. And then other cases would be if they have anxiety or depression, and we do a lot of screenings in those offices. So we'll see if they score high in the PHQ-9, which is a depression screen. And so if they're scoring high or they have any suicidal thoughts, I go in and do some intervention and some counseling and offer services for them.
Well, I think that's great because I did struggle with some depression earlier on when we were going through some really tough times. And I think I probably had that screening. I don't remember what it's called again, but it was done by a primary care physician.
Right.
And there was no, okay, you want some meds?
Right.
Yeah.
So luckily I was in therapy outside of that to help deal with all the other stuff, but I don't think most doctors' offices have something like that. And so it's actually the physicians who are doing the test, but they're not skilled in that.
And integration's very new. We're funded by a federal government grant right now to get this health home up and running is what it's called. And so the findings that we're having are phenomenal. Like, clients are just reporting that overall health factors are getting better. Like, their BMI levels are going down because
What is that?
their BMI is like your healthy weight.
Body mass.
Mass index.
Right.
Yep. So your healthy weight. So their weight's improving. Their high blood pressure's improving. There's all these different factors that we look at, and they're all improving because we're focusing on the whole person. It's not this primary care over here, your mental health care over here, and then substance abuse over here. It's all interconnected, and so they're really getting the best care possible.
Yeah.
That's amazing. That's really amazing. So tell us about some of the people that you work with and what they might be struggling with and how you can help them.
Okay. So the primary population that I work with is, so it's community mental health, it's community primary care, it's community substance abuse. So when we get community, we're working a lot with Medicaid clients. I would say a handful of my clients, majority of my clients I should say, are homeless. And they just need a lot of services and a lot of support. And so we offer a lot of that there. They also have intensive services so that they get really good care where they have case managers that are constantly checking in with them week by week. So they're not getting lost in the system or, how people get lost. So people will come in and, again, we do a lot of screening, so that will kind of give me a red flag if there's anyone I need to meet with or work with. At that time, I'll introduce myself and kind of give all the different services that I offer, which would be like smoking cessation, substance abuse counseling, chronic pain management, and then mental health services as well.
Wow.
Yeah, so it's a lot that I kind of can do with clients depending on their needs. Yeah.
Absolutely. I think that there's a misconception about homeless people and why they're homeless and all of this. What do you think? What do you see? Who are these people?
Yes. When I was working in detox, and it was just very interesting to me, one of the things that kept coming up when I was meeting with clients was divorce. That was a huge factor that created their homelessness.
Interesting.
Divorce that started, and then poor relationships that then caused them to start using alcohol or other substances to self-medicate their symptoms, which then put them on the streets, or the person that they were with put them on the streets, whatever it was, depending on their scenario. But a lot of that was a common thing that kept coming up was divorce. Trauma. Trauma is, I would say, 80% of the people I see, and that's probably underrated.
And is the trauma as an adult, or is it childhood trauma, or is it a combination of both?
I would say it's a combination, but a lot of it starts in childhood.
When we were working with our son who had reactive attachment disorder, we had been to an attachment specialist. And I remember saying to him, what happens to these kids if they don't attach? And he said, this is the prison system and this is your homeless population. Because a lack of attachment is a traumatic event. It's a trauma. And trauma causes you to not form empathy, to not have cause and effect thinking. So if I do this, that might happen. And a lot of times it causes a lack of conscience. So hence the prison system, because I can do whatever I want, and I don't care about you. I'm going to do whatever I want to survive, to get by. Nobody's watching out for me. I can't trust anybody anyway. Nobody's ever been there for me. So I've got to look out for myself, and I'll do whatever I have to do to make it happen. And that all happens because of trauma. And so you're dealing with people who have just been broken and wounded to the point where they don't know how to have relationships. They don't know how to hold down a job sometimes.
But the relationship comes in their form of addiction. The addiction is their relationship. It is their attachment.
Interesting.
And so when we have them come into treatment or into detox and offer services, they get very, very scared. And it's very real for us to say, hey, look, in order for your life to improve, we need to work on this addiction. It needs to be sobriety. Or we need to work on cutting back, whatever that is. And it's taken away their attachment that's helped them survive. And so it's very, very scary for them.
How do they do that? How do they let go?
That's a really great question. We're still trying to figure that one out.
It's not just an easy little
it's
method.
not, and it's very different depending on the client. So it's very individualized. What we're seeing, so the clients that I've been working with that have success rates or that are still sober, what's worked for them is a combination of medication and therapy combined, not just either or. It's kind of that combination, but really what we're seeing is a really big, strong support system. And so really incorporating AA or other supports like that into their lives. Celebrate Recovery is a great one too. Getting connected into your church. I really encourage the building of the support system. And then also looking at trauma, because if trauma is the mitigating factor here, we need to focus on that. You know, we can take the substance away, treat this part, but then down here is the trauma, and that's never going to help them improve or move forward.
Okay, so what is trauma? How do you define or describe that? What does it do to people?
So trauma is a big word. It encompasses a lot of different things. Basically, it's an adverse event in your life, and you can describe that however you want. It could be anywhere from a car accident to childhood abuse, to grief and loss even for some people. So it's really how you react to some stuff in your life that's happened.
And sometimes isn't it maybe the developmental age that it happens? Because I know with some people, like having your parents get divorced, it impacts them, but it's not this huge thing. But at certain ages or at a certain developmental level, it can just break a child,
Right.
you know? So it's interesting to see how the same trauma might impact different people in different ways.
Yep, age is a huge factor in that too. The brain is always developing until you're about 25, so between 0 and 25 is any type of trauma, it's going to really have a big impact.
And what's it do to your brain?
It changes it, completely changes it. The way you cope with stuff, trauma tends to stay stuck in your right brain, which is your emotional brain. And so one of the techniques that's out there right now is called EMDR to help people kind of process through getting the right...
Did that?
Did you? Good!
Yeah, and what they were saying is it's stuck right here, and what we're trying to do is get it moved over to here, and what that does, it sounds kind of crazy, but this is the emotional side of your brain, so you feel as if you're being traumatized. And if you can get it moved over here, you can remember it. It's not like it goes away, but you can remember it without it getting you all upset.
It's not that emotional charge like it was before.
Right.
Yep. So it's a cool processing event that they have, and it works wonders.
And it's called EMDR. EMDR. Which stands for...
Eye Movement Desensitization Reprocessing.
And it's a really interesting little thing. Literally, you get your eyes moving back and forth. And when you do that, it makes your brain activate the different sides from your right to your left brain. And when you start doing that, you can remember things, you can see events, and your brain kind of starts shooting all over the place, and it's like, wow, it's kind of an amazing thing.
It is amazing.
It's not scary, but it's pretty amazing.
Well, and it's a safe way to kind of process things, and you're in your own process. So it's not like talk therapy, which operates out of your left side of your brain. So you and I are having a conversation right now. We're primarily operating out of our left side. And when we operate only out of our left side, the right side kind of gets missed, and that's where we're holding all of our emotional charge. And so you're doing, EMDR allows you kind of be in your own process. So you're not really doing a whole lot with the therapist. You're kind of checking in, and you're in your own process. And so it's safe.
Yeah, they kind of ask you questions and guide you through it, but really it's kind of, okay, what are you thinking about now? And you just start talking.
I was going to say, I did a process similar after the birth of each. I've got 4 kids, and in order to prepare for the next labor sort of experience, I did a thing very similar to that, to kind of just sort of hit the reset button. Because there were a few things that had happened during labors with a few of them that really, you don't want to facing it again. I was like, but it was amazing how it did kind of set the reset button to where, of course, I didn't forget, but the emotional charge of it was taken. I could approach it as the unique and new experience rather than just it's going to be the same old and it's going to be this trauma again. It was a new experience every time because of that.
That's amazing. That's an interesting... You don't think of childbirth as trauma usually, but
everyone's own experience.
Absolutely could be. So that's interesting. So then as you're working with the patients with the trauma, how does trauma impact people?
So the way I see trauma in my office that I'm working with when I'm working with people is they're operating out of survival mode. So trauma kind of puts them in that survival mode, and you can see it. It's very difficult for them to attach to other people, have healthy relationships. The safety and security is a huge part of that. So it's really a lot of psychoeducation, getting them to understand, like doing a nervous system, like talking about the nervous system. What does that mean? What does that look like? How do we wind down that nervous system? What do we do for coping skills so that when you're, in this environment that you're not completely traumatized and being triggered and reacting rather than thinking? Because what happens in trauma is your prefrontal cortex disengages, it's hijacked. And that's the part of the brain that you really need to make like higher functioning decisions. And so your limbic system, which is your emotional response system, is really playing the role of survival at that time. And so we do things to get people grounded. We do deep breathing skills. We do I'm aware. So we go around the room, I'm aware of this, when they're looking like they're dissociating. And disassociation is a form of protection.
It's kind of like checking out.
It's checking out. We disassociate multiple times in the day normally. Just kind of like when you're daydreaming, that's kind of a form of disassociation. Zoned out. Driving, people will say, I got from here to here without remembering how I got there. But with trauma, disassociation is their survival. And it's what keeps them protected. So we try and bring them back.
Interesting, because of the years of chaos in our family, I'm struggling with some PTSD. And when you're talking about the frontal cortex, that's I'm not using the word frontal cortex. I'm like, my brain just shuts off and I can feel this rush go, and it's like instantaneous. And all of a sudden, I cannot think to save my life. I can't reason my way out of it. I can't try to explain to you what's happening. I can't hardly talk. I'm just like, I'm frozen.
Right.
And I can't make my brain work. And it's so frustrating and it's scary because, with my background and everything, I have a lot of logic. I have a lot of knowledge and I know what to do and I know how to tell somebody else what to do. But when it happens to you and you're just shut down,
yes, you are.
It's a really scary feeling. So having to learn those things, feeling the chair, that it's real and you're sitting here and my feet are on the floor. And, those grounding type things are very important. But how interesting.
And interesting that, these are things that we're talking about with our clients, like grounding and stuff that we do every day. But when you're in that trauma response, you forget about it. You don't even realize that you're not doing it.
And if you haven't experienced that, I think as well, perhaps you don't understand what a sabotaging place it can be, because it becomes your expectation of life and on that survival. So it's your expectation of experience and everything that you go to do, and it's a repetitive sabotaging of of relationships, of opportunities, and people. It's easy to understand then that slow or fast, however, slide into homelessness, into divorce, into all these things, and addiction, addictions, that really can happen because if you don't know better, it's all around you. You're surviving everything.
Well, and what I think is interesting too is your clientele happened to be mostly homeless, but there's a whole population of drug addicted people who are doctors, teachers, pharmaceutical sales reps, preachers, everybody.
Addiction affects everybody.
It does.
Yep.
It does. And you can't escape it just by thinking, well, I'll just have a nice house, or I'll just get an education, and then if I'm not homeless, I'll be safe. But really, it's this trauma stuff that kind of hijacks your life almost, and if you don't deal with that, and trauma's painful, so a lot of people don't want to deal with it, so they try to push it away, not deal with it, and then you have to start numbing because it's screaming to come out. So, how do you help somebody move into that place of healing where now you're taking away their cushion, their medication, their numbing device, their friend, their attachment, whatever it is, it's been everything to them. You're asking them to give that up and saying, okay, now I want you to feel this. What happens?
It's very scary for them because, again, they're feeling, right? And that feeling they're not okay with that. And so it's a lot of psychoed, again, we're teaching them that this is okay, this is natural, this is healthy for you to have these emotions. Your body is experiencing these emotions for a reason. We talk a lot about how to get that feel-good chemical in the brain that addiction gives you in a different form, like exercise. We talk a lot about exercise and coping skills, getting again into a big support system, what that's going to look like, a relapse prevention plan. Sometimes medications will really help with that initial piece of getting off of a substance.
Right, and it doesn't mean that has to be a lifelong thing.
Right,
it can be kind of a
temporary
bridge.
Yep.
Yeah.
Yep, exactly. And so there's a lot of different tools and techniques that we use when people are new into recovery or trying to get sober. But a lot of it is building your support system and having that ongoing therapy and connection with somebody and check-in and yeah.
Right. Now, do you see, what's the success rate like?
That's a tough one. It is. Addiction is really, really hard. I'm not saying it's not there, but the chance of relapse is really high. So as far as a number, I couldn't really give you one.
Do you end up seeing some of the same people back?
Yeah. Yeah, they might have 6 months sobriety, have a little bump in the road and end up back into treatment. But that's okay.
Now, one thing that I've heard is that sometimes it takes 2 or 3 times, and then something really clicks, and then they really believe they can do it. And it's like so much information and so much to process, and sometimes it's just too overwhelming the first time, and so they make it a certain amount of time or whatever, and then they go back because life gets too hard, and then they do it again, and maybe they make it a little longer this time, and then they fall off again, and then finally it's like they make it.
Right.
Do you see that?
I do, and I compare it to exercise. Someone that doesn't really exercise ever, they try to exercise for 2 weeks, they do great, and then all of a sudden they relapse, right?
I'm done.
Right, and so I want to normalize that this is a natural human habit behavior forming pattern, and not specific to addiction specifically, but general habits. Someone with smoking cessation, usually their first attempt at quitting is not successful. It's usually the second, third, fourth, whatever it is. And so to normalize the addiction for people, because addiction's so guilt and shaming and all those emotions that are connected that they already experienced themselves, and we don't need to be putting that on them more than they already experienced themselves. And so I really try to say, hey, it happens. It happens, yeah. Working out is hard too.
That's the weight of relapsing. Sometimes it's the shame and the guilt. It's I messed up. Oh well, I'm on this track. I might as well. Rather than I messed up. At least I'll feel better. I'm gonna pick myself back up, and I'm gonna get there. So.
Yeah, and every time they relapse, I always say that's a learning point. You learn something new about yourself that you didn't know before.
That's really good.
So instead of turning it to negative, we look at the positives of it.
That's really good.
So they can keep the focus.
Well, and you're going to go through it again. This time you're going to pick stuff up that you didn't last time. So you'll get your degree this time.
Yes!
That was actually how I ended up in the counseling program, because I had my counselor say to me, you know what? You've pretty much already earned this degree. How about you go and get the credentials?
You've done the work.
You've done the work. I just go do the book work.
Exactly.
All right.
University of life and hard knocks.
Exactly. Experience. Anyway, well, Megan, thank you so much for joining us.
Thank you.
This has been great, and we'd love to have you back. Are you up for
doing
another one?
Yes, I'd love to.
Awesome. Well, Jenny, thanks so much.
Thank you.
You did great.
Yay. I passed.
You passed.
I passed. Okay,
Will you come back too?
I would love to.
Okay, great. Well, thanks everybody for joining us, and we'll see you next time here on Broken and Brilliant.